Good evening, everyone. Welcome to the second episode of this year's MedAI Web Hour. I'm Dr. Aishwarya Sharma, and I'm very pleased to announce a very interesting session, which will be in accordance with the Society of Critical Care Medicine and Doctors AI. So we have with us three amazing doctors, Dr. Srinivas, Dr. Neeraj, and Dr. Saswati, and they will help us to understand how they are using AI in their everyday practice. So this is MedAI Web Hour, where we meet every second Thursday of the month, and we discuss the new things happening. We get amazing speakers who talk to us about how they inculcate AI in their practice, how they use AI for the literacy of doctors, and how they see the change happening due to AI in their medicine practice. So, to start with the session, we have with us Dr. Srinivas. He is a chief intensivist at Sindhu Hospitals, Hyderabad. He is the president of Indian Society of Critical Care Medicine. He is the member of World Federation of Intensive and Critical Care Societies. And his area of interests are neurocritical care, economics of ICU, safety, and quality in ICU. Very welcome, sir. Thank you so much for taking this time out and chairing the session today. So we have also with us two amazing speakers. But sir, first we would like to know about you and please introduce the speakers for us, for our audience.
Thank you very much, Aishwarya and HB, for having me and ISCCM along with my two friends, Neeraj and Saswati, in this meeting. We have two excellent intensivists, the emerging leaders of ISCCM AI brigade, I must say, Neeraj and Saswati. Neeraj is the Associate Professor of Anesthesiology and Critical Care at the All India Institute in Patna, and he is a very active member of the critical care group in which the ISCCM is actually running a course on AI for intensivists along with DoctorsAI. So we'll first start with Dr. Neeraj and then we will go to Saswati. Saswati is also a young and dynamic intensive care specialist from Kolkata. She is a senior consultant in critical care at Manipal Hospitals, Kolkata. So Neeraj will speak about a pressing problem about so many years after sepsis has been identified, several definitions and iterations of definitions of sepsis have come and gone. We are still debating on how to define sepsis in clinical terms. And associated with the diagnosis of sepsis, we usually deal with the use of antimicrobials. And again, intensivists and of course all medical specialties are struggling to enforce the concept of antimicrobial stewardship. So with the use of artificial intelligence, can innate intelligence gain some advantage in early recognition and strict stratification of sepsis and the use of proper principles of antimicrobial stewardship? That is the first topic for the day, and that will be done by Dr. Neeraj. Something very close to this, when you diagnose diseases where early, initiate therapy better, and you discipline yourself in the use of such therapies, your quality of care improves, which ultimately makes your ICU safer, which we have not been able to do so far with all the efforts. ICUs still remain some of the most unsafe environments in a hospital. Does AI help you in making your ICUs any safer? Is what Saswati will be talking to you in the second half of this program. So over to you, Neeraj, about how AI influences the recognition of sepsis and its management and the implementation of antimicrobial stewardship program. Thank you.
Thank you, sir. Thank you for your kind introduction and your blessings to have this opportunity for speaking on AI with sepsis and antimicrobial stewardship. And I'm going to share my slides. Thank you so much, MedSynapse and ISCCM. So, I will be speaking on artificial intelligence in sepsis and antimicrobial stewardship. Now, this is a very, I think, interesting topic if AI has been incorporated into it, because now we will be transforming critical care from reactive responses to predictive precision. So just I made it a bit interactive by adding a Slido to it, so you all can scan, and then just I want to know that how many of you are using AI tools for knowing that sepsis prediction, and this question is, or this poll is open for you all. So if anyone who is listening to this presentation, they can scan, or otherwise only to know that. How many of you are really interested in using these AI tools? So this is one of the poll that I have added to this presentation. So
So option one being yes and option two being no.
yeah. It is like that. So it's one or two, means it will show in percentage that how many of you are using that AI tool. So the number of people more will join. So we'll have that opportunity to see that okay, how many of them are using it, or how many of them are still not using for sepsis prediction. So I think two members have opted for that. Okay, so I will go later on, because I'm sure that many of them are going to join it again. And then this outline is that I will be talking about sepsis burden and challenges in recognition and management, and then AI applications in sepsis early warning system, and then AI for antimicrobial stewardship optimization, then implementation considerations and future directions. Now, the most important point is that why this sepsis is a global healthcare challenge, because you see that there are three parts. That first part is that what are the number of cases? So around 50 millions of cases there annually worldwide has been reported, and out of which 11 millions people are going to die. That's why the first important point is the number of cases. The second, the how annual healthcare cost in US alone, you can see that around 24 billion annual healthcare cost is there if you talk about only US. And each hour it increases the mortality by 7.6% if you delay the treatment. So I think based on these three background, the component for AI prediction is very important, or it's a very challenging for nowadays. Now, we are very much aware about these sepsis 3 definition and diagnostic challenges. But here I would like to highlight that why these diagnostic challenges, or there are various traditional scoring systems that have a limited accuracy, and that's why the for sepsis prediction, that it's a time delayed sepsis prediction is there, leading to more and more mortality. So how AI could be a important tool in optimal clinical recognition, so we will talk about that, so that to predict, or so that to hasten or to prevent the significant deterioration or late recognition. So, AI in sepsis is a digital evolution in critical care, from early prediction to precision treatment mapping, the role of artificial intelligence across patient life cycle. So, if you see that there is a journey map which just starts with a prediction, then diagnosis, then treatment, then monitoring, and then outcome. So, the challenges I already discussed, that the challenge is global morbidity and the high cost of treatment, and then there is a heterogeneous nature, as well as there is rapid progression of this disease. And then the technology, that what we will talk today is how these deep learning, like your RNA network, and reinforcement learning like your optimized antibiotics tool or AI tool, has important component for prevention of these sepsis or sepsis mortality, or early prediction of this sepsis. And then the goal is to transform the abstract algorithms into a continuous digital guardian, so using various tangible advantages. So now again you see that there is a golden hour of treatment versus the limitations of current diagnostic standards. So if you'll see that in y-axis, the patient risk, and the in x-axis the time. So the more time is there, if you spend 8 hours, 8 hours, if there is delay in the making a diagnosis, you see the how high the patient is at risk. And this is also known as the biological progression of sepsis. And you also see that how these traditional detections like SOFA and SIRS, if we depend on these scoring systems, we are typically missing a intervention window for which again the mortality or patient acuity risk is very, very high. Now, now again, a new concept for this, that the pre-hospital prediction is there, in which all things, all AI models are now working on hospital, not only on hospital arrivals, but on pre-hospital ambulance itself. So they are capturing all those real-time data, like structured data, like your non-structured data there. And one model is Northeastern model, which has got a 99% accuracy in predicting that tool, because they are using two important structures data, like your symptoms as well as vitals. And one Sierra algorithm is there in which 12-hour late time is there. So you can see that how the late time is improving, and you are earlier predicting the sepsis, for which the clinical onset is very late, but you are predicting it earlier stage. And yeah, and that's why this is one of the window that is shifting, and that window is pre-hospital prediction. So now coming to the next part is that how these algorithms are translating to survival. So if you see that absolute mortality reduction is around 1.9 to 4%, and this is in various prospective evaluation. And what they provide as a secondary benefit, that they preserve the organ, they have a subsequent lower SOFA scores. And now again, the important point is they are having more protocol adherence, like 5% improvement in the sepsis bundle compliance. That's why if prediction model is coupled, they time and their timely actions is going to save life. Now, if you see this time mortality equation, so scarcity is time, current mortality rate is around 10 to 40%, and golden hour of antimicrobial therapy is critical determinant of survival, which we all know. And so our AI tool is going to target this time mortality equation. Now, if we'll see that how this paradigm of shifting this paradigm from reactions to prediction. So it is based on the EHR data to identify patterns of invisible to human cognition. Like the application is based on early warning, then hypothetical analysis, and then death rate, which includes inpatient time, and then in after early warning, classifications of sepsis subtypes, then microbial your identification, and then web based on various AI models like partially supervised, self-supervised, or fully guided models, or reward-based learning models are there. Whereas for hypothetical analysis like of antibiotic treatment, the adaptive treatment as well as your adaptive treatment strategies is there. So the in this era of predictive intelligence, like deep learning era, so there is input data in the forms of vitals, the lab parameters, as well as these are time or various time series data. So these are going to have a for a features of your convolutional neural network, and then they will convert to your LSTM, that is long short term memory, which is a temporal or time associated analysis, and then they uh, give a output in the form of sepsis prediction as a pre-symptomatic outcome. Now, one important concept is about your MGP RNN, that is your multi-output Gaussian process as well as a recurrent neural network. So basically, it's a Gaussian process interpolation in which what happens basically that there are various irregular data like vital signs and lab results. They have a massive gaps when you will try to record all those things. But using these solutions of MGP RNN, that is your Gaussian process interpolation, these forms a recurrent neural network, and then they predict your sepsis. That's why this Gaussian process of AI, they fills the gap between the checks, and they provide a continuous stream of AI to analyze. So this is how a watch over system takes place using deep learning method. Now, similarly, it is like input, like your raw data, because previously, if you want to compare the only the irregular data like vital signs, so they are more linear in relation, and they doesn't have a potential of analyzing that inputs. But after addition of MGP imputation, and after that recurrent neural network processing, they are having a risk score as a predictive outcome. So this is how a mechanism that how a AI sees a sepsis. So there are three parts. I think this is very interesting and conceptual slide in which you will see that there are three parts. Like first, there is a fuel, there is an engine, and there is an output. So in fuels, the fuels are basically the inputs. Like we used to give inputs in the form of structured data, which is your vital signs, which is your lab parameters, which is your medical or EHR records. The unstructured data in the forms of your clinical notes or x-rays. The high frequency data like bedside monitors. And the third and the fourth important point is your pre-hospital data, that is your ambulance data. So all these are fuels, all these are inputs. Now they are going to process as a in an engine. So this is a very complex non-linear pattern which is invisible to human assessment, and then they produce an output like as a predictive alert. So further, if you dive more into this engine, so this engine is basically gradient and gradient boosting, and they have ensembles. Why these are ensembles? Because they are various architecture like XGBoost and gradient boosting, which these have what they do basically, they ensemble the learning, and they basically they combines the weak models, and then they start they start doing that corrections in a very sequential manner, and then they produce a strong predictor in the forms of either like in the forms that even impending a shock before a hypotension has appears. So it is like that. So it is, I think, this is the model that has to be discussed, and it is very, very effective. Now coming to the important aspects, that how these deep learning like identifications of non-linear pattern in complex data sets, that waveforms that happens. And then the second part is your NLP, that is your natural language processing. Basically your clinical notes will serve as a natural language processing. And then third part is how they capture, and then they produce the clinical signals that the traditional scoring system must is going to miss, like your news, like your SOFA scorings, like your earlier Apache score, SAP scores. All these scoring have their limitations. Now, these are the high dimensional data ingestion, where all those structured, unstructured data are high frequency data. Pre-hospital data is going to provide a predictive signals for detection of AI. So this is, I think this is again an important slide. Why? Because in this you can show the how these area under curve showdown, they compare the precision versus convention. So this is a very statistical leap in performance. You can see this metrics where MGP-RNN, that is your recurrent neural network, as well as your Gaussian process, which is much better over clinical standards in their AUC curve. You can see that using an AI model, the AUC is around 88%, whereas the QSOFA or news or SERS is in a value of close to 50 to 70%. So why this key metric is important? Because this is the window of opportunity where these MGP-RNN model that detects the sepsis a median of at least 5 hours before the starting of clinical onset. So what is the operational impact? You see that around 10.5 out of 17.9 daily cases, you are going to have an alert every 3 alerts per hour. Similarly, if you have used the SOFA score, you have identified only 2.21 of cases, daily cases, with such a lower threshold. But using this MGP-RNN AI model, I think it's a good operational impact. Now coming to the important aspect, that why the gap was there using this traditional scoring. So you can see that what is the limitations of the traditional scoring, because the data capture was a linear one. It's a linear one. That's why they have more they have because their thresholds were missed. Early signals, all those early signals were missed using those traditional scoring systems. But whereas and because of that host response complexity, it again provides another limitations for these scoring systems. So now moving beyond that one size fits all sepsis endotypes, that there are three endotypes like A, B, and C. So these are based on the phenotypes and biomarkers, and you can see that how these patient clusterings are there based on your metabolic dysfunctions and immune activation. So that is another targeted therapy groups in which few of them groups will respond to corticosteroids, few of them will have a fluid strategies, few of them respond to some other forms of treatments. So based on this one size fits all is not adequate now. Now, again, the second thing is the concept for your AB framework, that is optimized antibiotics framework model. Now, what is this? It is a form that is this sepsis or to how do we treat it? So now the challenge is 30 to 70% of the patient have no detected pathogen initially, but treatment is often empirical and blind. And the solution is your AB framework. Now, what is this? This will minimize the SOFA score, like treatment success in the form of treatment success, and then it also predict the side effects of that antibiotics leading to the toxicity. So it maintains a balance between your treatment success as well as toxicity. Now, important thing, how they use the data, how they use the data. So they measure, they encode, they assimilate the data, they propose, and then they predict. So this is like the how these opt AB really functions. So for better understanding, this is one of the precision strategy in which treatment effect control differential equation is there, in which the data is assimilated in the form of SOFA score, in the form of lab values or vital signs. Then it gets encodes. After encoding, they gives a solution for optimal treatment, because they decode that treatment part, and then they forecast the disease progression. So this is how the mechanism, the innovation, and the dynamicity work, and they update every 1 to 2 days, and that's why it is a next treatment iteration. I think it's a very important antibiotic precision strategy for antimicrobial stewardship. Now, what will happen, how it is going to benefit to us? Because what happens, many of the time, if organ failure is there, so might be what we are seeing, that we are using various antibiotics like vancomycin or ceftriaxone, so it will have a nephrotoxicity, because it nephrotoxicity and hepatotoxicity. But using this opt-AB, they can predict the creatinine level, they can predict the bilirubin and your alanine transaminase level or transaminitis, and they assess that risk of liver injuries leading to, because they have capability to forecast these specific lab values within 48 hours into the future to prevent the injury before it actually happens. So this is one of the important thing, that race against time. That's why I have added this, because the clinician, they choose antibiotic within 1 hour, and the culture takes around 2 to 3 days. So this is also known as carpet bombing with broad spectrum antibiotics, leading to more nephrotoxicity or hepatotoxicity. So it could be prevented using this opt antibiotic tool. Now, this is another important aspect, is what is counterfactual. So counterfactual trajectory basically is a model prediction how to validate this model prediction in the against the real world, like in three categories. This is in they compared the time in hours with SOFA score. You see that if ineffective treatment is there, the SOFA score is high, and the timing is more. But if you provide optimal treatment, the fall in SOFA score is there, in spite the you are going to treat it for a longer period of time. So the providing optimal care is having a drastic improvement in the SOFA score. And even if you are providing a standard care of treatment, the SOFA score is almost hovering to that same level that what you see in this slide. So that's why this counterfactual trajectory is there, where it allows clinician to parallel the treatment realities with real world against that real world. So now again, some success stories of three important tools, like John Hopkins tools, which is your emergency early warnings system, then Northeastern University. So they have used approach different approaches. Like in Northeastern University, they have approached three stages. Like they have captured data from pre-hospital and then ED, and their accuracy for predicting septic shock prediction is around 99%. Whereas the John Hopkins tools data, they have a 32% increase in early detection, and they provide a lead time of around 4 to 12 hours before pre-onset, before the clinical deterioration exactly starts. And few of them are pediatric models. Now, if you'll see further clinical validation, I will just talk here that the takeaway is they are high performance, maintainable in real world, and even in the multi-center environments with area under curve performance of 0.94. Now coming to the another aspect of black box and trust gap. Now what is this? Because this address the friction between the high accuracy and low interpretability. Because 12% of the doctors, they believe that AI models improve the diagnostic and treatment services, but the solution is explainable AI, which basically records a a thin line designed like they can track elevated lactate, and if the BP is dropping, so they will give a alert. So this is I think this is again a value of trust, in which validation within 3 hours, it reduces the antibiotic administration by 1.8 hours. Now, this is again very interesting slide, I think, from black box to bedside, where these black box, they trust the gap. Why? Because the transparency is the barrier to adoption. The first point, because clinician most oftenly reject AI recommendation because they couldn't understand, or they couldn't able to verify it. And the second point is there are three tool sets like SHAP, like Lime, and like GradCam. I will talk about SHAP only because this SAP is basically it's a safely additive explanation, in which what happens here, they are basically they are a player, because they gives a prediction as well as they give a direction. So magnitude and direction can be defined like that. The lactate has some values, and then mean arterial pressure has some values. So they used to guide they used to guide as well as they used to direct. Whereas your grade cam is basically, it's a gradient weighted class activation mapping, which is based on your heat map. So it captures the different zones in images, like in X-ray. If they want to have that predicting pneumonia, so it can have a red zone or something like blue zone, something like that. So these are the some XAI or actionable AI tool sets, and they have 73% of predictive power. So if they compare this model from traditional to explainable like BioAlert, you see on this slide that how this sepsis 3 traditional finds have a rock of 8.85%, whereas the false positive rate was 20.8%. But using a BioAlert like explainable AI, the AROC is improved, whereas the false positive rate is going down. So this is again an important aspect, that how it is important. And the second is it has a relative decrease in mortality. So now coming to the next, I think poll here again, how many of you are using AI tool for diagnostic workup as a part of antimicrobial stewardship? I think anyone who want to attempt it. So I think I will go to the next slide. Coming to the antimicrobial stewardship, that precision therapy, moving to one size fits all to AI guided precision. Now using this antimicrobial stewardship AI tool, now what they does? They basically distinguishes non-infectious inflammation from true sepsis. They provide a response prediction. They optimize the regimens, and then they do a stratification like low, medium, or high to determine the intensity. So for further better understanding how these AI in antimicrobial stewardship works, so if you see that there are bacterial infection, there are viral infections. So these biomarker signatures, these machine learning identify gene expression patterns, and then they differentiate or distinguish between bacterial versus viral etiology with more than 90% accuracy. So basically, it rules out the bacterial infection early to reduce unnecessary antibiotic use, and based on the autophagy classifier. So this is another important aspects of AI in antimicrobial stewardship. They again provides precision prescribing and de-escalation. Now again using this composer technique. So this composer technique is basically your conformal modularized prediction for sepsis risk. It is a AI sepsis early warning model, where they stratify, and the second part they use it has been used for descalating the therapy as well. If the patient stability is confirmed, then you can reduce that, or you can descalate the antibiotics. So by using this composer system, the mortality reduction is there, and improvement in the appropriate descalation is also there. So we can shift from empiric for all to target for one. Now this is again the stewardship evidence and optimization. You can see that how these they provide accuracy, which I already talked. They help in doing that descalation, and they help in improving the clinical response rate. So there is AI benefit and a legal consideration, like ethical and legal consideration using AI benefit and ethical consideration, because there are some liabilities concerned when patient outcomes are AI influenced, obviously, and there are some ensuring algorithm equity across the diverse groups of population, and then patient data privacy protections. Now the human in the loop workflow, like this, how alert generation, how a standardized assessment using human and AI score, and then targeted action. So this is deployment focus to high risk areas like ISU and your ED, because it has a grade A recommendation, and these AI supports the judgment and it doesn't replace it. So these are the few challenges like alert fatigue, because high sensitivity of the data leading to more false positive and clinician burnout. But yes, the false positive are not much high that what we used to get using that traditional tools. Whereas the algorithm bias that will be there because of the model learning from documentation patterns from various rather than the physiology, and then generalizability because it doesn't fits to every model. Like academic centers model may fail in community settings, and then infrastructures because deep learning requires computational resources. The coming to the future direction is that the area of precision sepsis care, that like your multimodal integration, wearable EHR data, federated learning, and then genomics. So you have to shift from reactive management to precise precision, which was in my first slide. And then the goal is for making faster diagnosis, smarter stewardship, and reducing the mortality. Further future like explainable AI, in which I talked about how this traditional AI is different from your actionable or explainable AI, and then how these multimodal AI using your genomics and clinical data, and then point of care by incorporating your rapid diagnostic into real-time predictions. So the key take-home message is AI sepsis detection system consistently outperform the traditional methods. AI enhances the antimicrobial stewards through personalized recommendations, and successful implementations require workflow integration and interpretability. And then future research should focus on validation, equity, and implementation. So thank you all of thank you, and I will be happy to take any questions.
There is one question for you, Deepak. When Neeraj, when AI actually flags something as sepsis early, but clinically you don't agree with it, or clinical just says no, this is not sepsis. How do you get, the middle path, or how do you actually approach this decision? What would you trust more?
I think, sir, I have already discussed it. One of the finding in the black box part that many of the times these AI interpretation, like in clinical decision severity scoring, like CDS's timelines, maybe these AI gives that the algorithms for for something which we usually doesn't know, or as a clinician. I think it's a learning tool, and we all are learning in it. And I think it's a tough question to be answered, because still we all are not using that AI too much, and not using that AI tools and all in our clinical practice. Few of them must be using that. I don't have any means experience on, because we are still focusing on that our clinical decision, and what the algorithm or what the evidence-based guideline says. So if
So,
you want to add something, sir, it will be fine.
no, no, that's fine. I think you got it right. What I'm saying, the next question for you also is accountability. Now, you make a decision based on an AI-driven algorithm or a support system or a protocol. How does it support that is in direct conflict with what institutional protocol or standards, the infection control team protocol? Now, how do you handle that situation?
I think again it's a tricky question to be answered, because now important is that once these tools or the tools validation is there, and if you because if these tools are validated, or if you are want to incorporate into your setups, like for hospital infection control committees, means or like definitely it should be I think two important point is I want to highlight here is the role of your data law officer as well as your data protecting officers, because how we are going to get protected from that part in working in an institute. I think it's a long way, but definitely something will come, or for some hope will be there for we all of us. And then I think the clinical decision part and integrating this AI tool for better patient care will be there, I think, in future, or in India soon.
Yeah, thanks, Neeraj. We'll go to the next part of this program, and that is about how AI can improve our safety standards and quality metrics, adherence to quality norms in the ICU. That's another important area where intensivists are struggling to actually come to terms with some of the challenges. So let's hear Dr. Saswati Sinha speak about the impact of AI on ICU quality and patient safety. Saswati.
So good evening, everyone, and thank you, Dr. Srinivas, for this opportunity. And I'll be focusing on the role of AI in enhancing patient safety in ICU. And as Neeraj said, that there are a lot of new concepts, and I think in days to come, we'll probably see this as reality. So, why is ICU patient safety an important concern? It's because we are dealing with a very data dense environment. We are dealing with monitors. We are dealing with the ventilators. We're dealing with data from multiple sources. And since our decisions become time critical, it can become cognitively demanding in a very busy ICU. And that's the reason that even despite using our conventional protocols and checklists as we do it on a day to day basis, trying to make patient care as safe as possible, we often cannot prevent harm, which happens and then we regret as to why it happened. A lot of it could be attributed to the traditional tools and the lacunae because we often rely at the moment on intermittent and static assessments rather than from a minute to minute evaluation of a patient's course. And oftentimes there could be early warning signs which may be present, but they are subtle and they are not integrated in the decision making process. That's the reason probably we realize the harm too late. So, where are the situations where patient harm can occur in the ICU? Most often could be a delayed recognition of clinical deterioration, for which we are also very well abreast of the fact that although we often hear that the patient suddenly decompensated, but if you actually go back and look at the records or look at the vitals, even now that we do not have AI, we see that there are missed important opportunities where if it could have been picked up earlier, the patient might not have deteriorated, or we could have done something in order to prevent the deterioration. There could be certain ICU acquired complications. ICU is also very dense with devices and a lot of medications, so there could be medication and device related adverse events. And of course, alarms coming from so many different sources, along with manpower shortage, can also lead to a lot of alarm fatigue and workflow related gaps. So, there are several situations where there is a chance of the patient being harmed in the ICU. So, what do we mean by the use of AI in critical care? As we heard from Dr. Neeraj, that artificial intelligence systems can learn from patterns from large data sets because there is continuous streaming data from multiple sources. Apart from that, it also analyzes data from what we write about the patient. Often, when we write, we probably don't do a deep thinking about it, but the artificial intelligence models can also read that. And machine learning often analyzes the longitudinal trends of the different parameters rather than focusing on single values, and which is a little different approach as compared to the one time severity scores or intermittent severity scores such as Apache and SOFA. However, we need to re-emphasize that these models are designed not to support, designed to support, but not replace clinical decision making. So, in a high intensity ICU where you have very, very sick patients overall, if these kind of tools can give us alerts and make our decision making better, they would be beneficial in improving the patient's safety. So, how does AI function for early detection of clinical deterioration? By continuously integrating the physiologic and the laboratory data, it goes a long way in predicting shock, respiratory failure, cardiac arrest, and acute kidney injury, all of which are serious problems in the ICU, which we see on a day to day basis. The alerts are generated hours before the patient overtly decompensates. It does it by trend based recognition, it raises preclinical alerts, thereby facilitating timely escalation of care. So, if we detect early before the patient decompensates, we could timely escalate and avoid adverse outcomes. In addition, during the course of the ICU treatment, there could be certain high impact preventable complications, which we are mainly going to focus on today, out of which delirium, ventilation safety, which is a very important factor, preventing hospital or reducing hospital acquired infections, hospital acquired pressure injuries, hypoglycemia, venous thromboembolism. These are things which we face on a day to day basis. So, if we get an assistance of AI in preventing these common ICU harms or even detecting them early so that we have a timeline where we can intervene in order to minimize these harms, that could be of great help. And apart from direct patient care, AI could be used in order to automate the workflow, thereby standardizing handovers, because often we see, and it's not uncommon, that a patient goes from the ICU to the ward and an important medication got missed and which could lead to critical events. That's something which could be actually avoided if we use AI to automate the workflow. It could also help in implementing hand hygiene, both implementation of the practice as well as surveillance, which could help in infection control. And as we mentioned, that it could play a big role in medication safety in order to predict adverse events and medication errors. So, like we said, that artificial intelligence can help predict shock, cardiac arrest, respiratory failure. Acute kidney injury is something which is very important and occurs very frequently in the ICU. And the traditional markers like creatinine and urine output, they often take a long time, or rather, they show abnormalities by the time the AKI has already set in. We, artificial intelligence models can use complex ICU data. They look at the vitals, they look at the urine output, they look at the laboratory parameters, the medications which are being used, and they do a dynamic risk assessment. And they mainly look at the trends of, say, the rise in creatinine or the trend of decrease in urine output rather than the absolute values. And there are models which have been shown to extend an early warning by 24 to 48 hours of advanced prediction, which gives a significant lead time for intervention, which helps the clinicians to enable proactive interventions whereby we could improve patient outcomes and reduce kidney damage. So, like Dr. Neeraj mentioned, that if it looks so magical, what can the models be doing? They actually look at the comorbidities, like the risk factors of acute kidney injury. They look at the vital signs and they also incorporate the creatinine, urine output, and the novel biomarkers. So, a huge range of data is assimilated, and that's how it can improve early AKI detection in the ICU. Now, coming to ICU delirium, up 30 to 80% of the patients in the ICU can suffer from delirium, and it does not have only short acting impact, but it also impacts long term outcomes, including mortality as well as long term cognitive decline. Even in a very good ICU, the manual screening is often reactive. So it's only when the patient starts becoming agitated, if the patient starts trying to get out of bed, trying to pull at the devices, the endotracheal tube or the central line, that's when probably the alert is raised. But there are the AI models which have been tested and which don't look at only the electronic health record data, but they look at the vitals, the labs, the patient's medications, the age of the patient, as well as computer vision can play a very big role in detecting delirium in the ICU. So if there is an in-room camera and it already starts seeing the patient moving around, trying to pull at the tubes, that could raise an early alert that probably a delirium is setting in, and this is probably the time to look at the medications, the risk factors, and try to optimize them in order to prevent delirium from progressing. And these models have shown a real world outcomes as to fourfold increase in delirium detection, which can also prompt the clinicians to have a look at the medications, lower daily doses of benzodiazepines, which can contribute to the delirium and can provide earlier opportunities to identify the high risk patients and proactively optimize the sedation, promote early mobilization, and try to take care of the delirium as early as possible. And there are these models when they have been looked at, it looks at the age, it looks at the BNP levels, elevated lactate, some ventilatory parameters, creatinine, and certain medications, which help to identify why is this model trying to say that this patient is at high risk of delirium. We know that mechanical ventilation is life saving, but again, injurious mechanical ventilation can lead to complications. And precision lung protection and preventing ventilator induced lung injury is often sometimes a focus which we look at from day to day. But again, how often in a busy ICU are we actually looking at the lung compliance? How often in the ICU are we looking at the driving pressure? And even if we are monitoring it, how often are we coordinating all of these and trying to look at how injurious this particular ventilator setting is being to that particular patient, because each patient is different, whereby we are trying to mitigate the volutrauma, barotrauma, atlectrauma, and biotrauma, which are the primary drivers of ventilator induced lung injury. AI can help in detecting asynchrony, whereby we can optimize the ventilator settings, because often what happens as a reflex to asynchrony, we usually increase the sedation. By increasing the sedation, it can increase the additional days of the ventilator and can increase the risk of ventilator induced diaphragmatic dysfunction. AI models can have also shown a lot of scope in optimizing the weaning and extubation, and some of the high accuracy prediction models have an area under the curve of up to zero point 0.9, and also helps to balance out not too early, not too late, because if we prematurely extubate, again, we can lead to respiratory collapse and reintubation, which comes with a very high risk, as well as if we go too slow, then we may be unnecessarily prolonging the ventilator, leading to infectious complications, muscle wasting. Does it do it? Because we probably, even if we do it very closely, maybe the best would be once in an hour. But here it gives dynamic 3-minute updates every time for an optimal weaning and rapid changes. And again, the closed loop ventilation is increasing the uh, the chances of the patient being optimally ventilated, significantly reducing the risk of manual adjustments and human error. Again, hypoglycemia is a very important risk in the ICU, and it comes with a very high hospital mortality rate and implications on the cardiovascular, neurological implications. It can lead to an increased length of stay. And probably this is why it happens, is because we often wait for a threshold for a trigger to start. There is often a very high nursing workload, so manual blood sampling and insulin titration can increase the staff burden and the potential for human error. How AI drives it is probably going from a, a reactive to a proactive role. And it has been shown that they could raise a predictive alert 30 minutes before the actual hypoglycemia set in. And there are a lot of things which come into the picture. Models can evaluate 70 plus patient features, which include the nutritional status, the organ dysfunction, the patient's personalized response to the insulin, which could be very extremely variable over a period of time, And it has shown that AI predictive systems can consistently reduce time spent in hypoglycemia and severe events. And in future, probably glycemic control is going to be a major domain where AI would probably help in improving safety in the ICU. Similarly, venous thromboembolism remains a leading cause of preventable hospital death. The traditional scores often do not function very well. And there have been trials. This was a trial which was randomized controlled trial on clinical decision support based on an AI model, which showed a 46% reduction in hospital acquired venous thromboembolism as compared to the control group. And it performed better than the traditional scores. And this probably the latest venous thromboembolism models, they actually look at the patient's risk factors, the immobility, they look at the CRP, the D dimer, they look at the patient's clinical features, and that is when they raise an alert to the clinician to actually think, because the clinician was probably busy managing the acute issue, and the prophylaxis could have been missed. The future innovations, it's important because why is it still not a part of our clinical workflow? Because most of the research has been retrospective, and in the years to come, probably implementation of these kind of models and validating it in our setup can make it a part of our workflow. As Dr. Neeraj mentioned, that sepsis, AI can actually revolutionize sepsis management. Similarly, hospital-acquired infections can have a huge impact not only on the patient outcomes, but can also create a huge economic burden. So AI-driven care continuum can look at the patient subsets, can identify the risk factors, and it is a continuum from the time the patient is admitted till the identification of the real-time alerts like fever or hypotension in a patient who has a central line, and can trigger the management much better. But however, it is again important to integrate people and systems, because none of the systems can overcome the without the clinician in the loop. And it's also the stakeholders who need to understand that the hospital infection control teams in the days to come, that if we can overcome the deployment challenges, it can translate into demonstrable quality gains. Similarly, hand hygiene, we know it's a very important pivotal part of the infection control. And looking at electronic sensors and the cameras in the room, there are AI models now which can not only look at the surveillance for the hand hygiene protocols, but some of them are well equipped to even look at the different steps of the hand hygiene protocol. So probably very soon, retrospective manual audits can go transition into proactive surveillance in the years to come. Talking about pharmacovigilance, like we mentioned, there are a lot of drugs in the ICU. The patients come with multiple comorbidities. The physiology is disturbed. There could be organ dysfunction and altered pharmacokinetics of the drug. So artificial intelligence can help in the prediction of the drug or treatment response, can help in personalized dosing, especially patients on extracorporeal therapy, can help in clinical decision support, and can also serve an important role in research as well, in order to transform clinical pharmacology in the ICU in collaboration between the AI and the ICU experts. Predictive models can anticipate adverse drug reactions and drug-drug interactions, which could be missed by human alerts. And as we saw that there are multiple machines which can set alarms, it has been shown that it can lead to sensory overload, leading to the people silencing the alarms and not looking at the problems. However, AI filters and artifacts can filter out the false alerts to a significant extent, allowing the staff to prioritize genuine deterioration. So, to summarize that, again, AI in healthcare will probably revolutionize patient safety and hospital efficiency by using early warning systems for critical care, eliminating human errors, by using smart IV pumps and automated order systems for medications. Pharmacogenomics in the future will use the genetic profiles with optimal drug doses for particular patients. And although the stakeholders will need to also pitch in order to make sure that the adverse events are reduced, resources are optimized, and the administrative workflow becomes more efficient. So this is the future AI framework, which has involved 117 experts from all continents and has come up with the 6 pillars, which leads to fairness, universality, traceability, usability, robustness or validation, and education, that is clinician training. All of this has to work before we can incorporate AI in our day-to-day work. So in future, it will be a collaborative future, and AI will not replace the intensivist. However, the intensivist who uses AI will probably have an edge over the intensivist who does not. So thank you very much for your attention.
Thank you, Saswati. That's a very crisp but to the point description on how safety and quality can be improved with the use of AI. So I can't find any questions for you. But I have a question for you. Now, when you look at safety and quality metrics, now, how do you factor the nursing ratios, the infrastructure, the bed space allocation, vis-a-vis the parameters? Can that be integrated into an AI-driven recommendation system for the administrators?
I think so, because AI will actually, if the administrators understand the importance, and in that case, and they are willing to look at the nitty gritty of it, I think the manpower allocation and all of those things will probably be a part of the whole picture, and they will have to really start looking at resource allocation depending upon the patient's surge or the acuity of the patients in the years to come.
Thank you. Thank you very much. So I think we had an excellent discussion and excellent recap of what AI can do in key areas in the ICU. So over to you, Aishwarya and HV.
Yes. Thank you so much, firstly, for conducting such a beautiful session. I understand that this MedAI Web Hour was a prelude to the Criticare 2026 that's happening. So would you like to say a few words about that, Dr. Srinivas?
Yeah, so the Criticare 2026 is the 32nd annual Congress of the Indian Society of Critical Care Medicine, happening in the southern Indian city of Chennai. This is the first time that we have a synergy session with DoctorsAI, where we are again discussing key aspects of the influence of AI in intensive care. This is an offshoot of the ISCCM's DoctorsAI Critical Care AI course, which we are running. So it will be a synergy between intensivists and AI practitioners and AI developers. Apart from this particular session, there is a big datathon that's happening in Criticare on the 25th and 26th of February as a pre-conference workshop for 2 days, where data scientists and intensivists together will work on real-time analysis of data. So I would invite all those who are keen to learn about AI and data science and data analysis to enroll for this meeting. Thank you.
That's very exciting. We are living in the exciting time of the intersection of medicine and AI, and it's very wonderful to see that we are having these datathons and hackathons, which help us actually, inculcate AI in our everyday practice even more practically. Thank you so much. I appreciate the clarity with which Dr. Neeraj sir and Dr. Saswati ma'am explained how the AI models translate the algorithm to the actionable bedside decisions. These sessions like these help us a lot with bridging the gap between the technology and the patient safety really well. So thank you so much, Dr. Srinivas, Dr. Neeraj, and Dr. Saswati ma'am, for taking time out. And for just imparting the knowledge to all of us here at DoctorsAI. Thank you so much. Another announcement that I would like to make is that we have Doctors AI Global Summit in 2026, and there is a golden opportunity for early bird registration till 15th of Feb 2026. So please take a screenshot of the screen, scan the QR code, and register online to get the early bird registration perks. So thank you so much. With this, I conclude today's MedAI Web Hour. Thank you everyone for your time. Thank you.